endocrine pathophysiology. So this will be a much wider perspective. We're going to cover the various parts of endocrinology and how disorders can happen, what are the normal physiology. So Dr. Alapan, what are the more common causes of endocrine disorder that we see?
We mostly see disorders like growth, short stature.
No, you're talking about the classic. I'm saying that from a pathophysiological perspective, what all problems can cause endocrine deficiency, let's say. Let's start with deficiency.
So deficiency could be due to the inadequate production from the gland, or due to that inadequate production could be due to the destruction of the gland or any antibody blocking or something that is not producing enough. Disorder could be due to antibody binding globulins that are taking the antibody to taking the hormone to its working place. Disorders could be due to the receptor at the receptor level, whether the receptor is not present, whether any antibody is there, whether resistance is there, or post receptor can be some issues like PHP where post receptor.
So if you start off first, you didn't talk about the developmental issue. The gland is not developed properly. Second, the gland is destroyed, which you talked about, surgery, trauma, not just autoimmunity, there can be a lot of other causes which can cause that. Then gland is there, but the hormone is not being produced. Then hormone is there, it has not been transported. Hormone is reaching the target tissue, but it is destroyed because of the enzymes. Receptor is not there. Post-receptor problem can be there. What could be the problems of excess? Like when will you have excess in that perspective?
Excess hormones.
Yes.
If feedback inhibition is...
So let's go start from the beginning, from the gland.
If more stimulation
Yes.
from the hypothalamus.
From anywhere. We are talking about generic conditions, so not hypothalamus.
If more secretion of hormones.
Yes.
There. No regulation or of that hormone is present.
Okay.
Upregulation of hormones, receptors.
Receptors are more active, or receptor is acting without the ligand. The gland, so the gland is producing more, very simple, whatever reason. The gland is damaged and you have the store which has come out in the blood circulation. Your binding globulin is less, so you've got more free hormone. The hormone is being activated more at the peripheral site. Your receptor is hyperactive, or there is a post-receptor modification. These are the broad ways, and we're going to talk about the various aspects from that perspective. This is a very important session from that perspective, because this is going to talk about the entirety of pediatric endocrinology, and we will be focusing on different aspects from that regards. So that becomes important from that regard. So first of all, what really is a hormone? What do you call a hormone? We need to talk a bit about hormone structure. That's very, very important from a physiology perspective. So hormones are broadly either peptides, which we all know, which can be small, like all the hypothalamic ones are usually small peptides. Complex, like growth hormone and prolactin, in which you've got multiple chain. Insulin also has got 2 chains. You have got TSH, LH, FSH, which have got glycoprotein structure as well. Then you have got steroids, and all these adrenal, testes, ovary, they are all steroids. And then you have amino acid derivatives like thyroxine, epinephrine, and norepinephrine. The chemical structure plays an important role in their mechanism of action, in how they travel, how fast they act, and a lot of other factors from that regards. So peptides basically are water soluble. They will be very good swimmers. They don't need any binding protein. They will directly go to their scenario. Binding protein is not required. But binding protein is also important in protecting that particular structure. So what will happen to their half-life?
Increase.
No. So if they have no binding protein, will they be saved from destruction by the enzymes, or they will be more destroyed? They will have decreased because they are open. They are roaming in the open. While if you have a binding protein, which is like a boat or a submarine, you can say, on that you are going, you will be more secure. So all peptides are rapidly washed off. You talked about vasopressinase, you talked about insulin. They are there for only few minutes. They will just go off. And enzymes will degrade them very quickly. So they have got very quick onset of action and short half-life. Peptide cannot go into the cells. So how are they going to act? They need to have receptors in the extracellular region. Very importantly, structure of peptides may overlap. So these are the four classical glycoprotein hormones, the LH, FSH, HCG and TSH. The alpha subunit is the same, the beta subunit is overlapping. So one can act on the other in that regards. So if you have got more TSH, it can act on the LH receptor, it can act on the FSH receptor. Acting on FSH receptor, it will cause ovarian cyst, largely big ovaries, and it is also going to cause macroorchidism. So these are the two scenarios which are there. Placenta produces HCG, which is looking like TSH, and that's why at very huge amount it can act on the TSH receptor to cause what is known as gestational thyrotoxicosis. HCG is actually so similar to LH that the receptor of that is known as the LHCG receptor. And HCG regulates the testicular growth. So in scenario where you have got more HCG producing tumor, you will have peripheral precocious puberty with slightly enlarged testes from that perspective, which becomes important. Now, steroid hormones are fat soluble, so they cannot really swim in the blood. They would need a binding protein. Now, this binding protein is more like a big boat or a submarine, as I said, which will also protect them from enzyme activity. So, whenever you look at the half-life of steroid hormones are much, much longer as compared to that of peptide hormones. And since they are lipophilic, they will easily cross and they are going to act largely on the intracellular receptor in the target organ. Amino derivatives like epinephrine, norepinephrine, where do they act? Do they act on the cell membrane or inside? So they act on the G protein coupled receptor, typically on the outside, while thyroxine is different, it goes inside the cell. So amino derivatives are water soluble, so they would again not need a binding protein. They have extremely short half-life. When you want short half-life, because why do you want short half-lives for amino derivatives?
The longer duration, it got much more effective. So epinephrine fee secret, for longer duration.
So the rule, what is their rule? So if suppose you have got epinephrine for acute management, why do you want it to be there for few hours? So if you have got PTH, you also want the PTH to go in 5 minutes. Otherwise, hypercalcemia will happen. If you want AVP, you want to go off in few minutes. But if you have done a lot of effort to produce a testosterone, it needs to be there in the blood and it's not going to cause too much problem immediately. So that's why there is a difference in terms of their half-life as well from that regards. So they have ultra short half-life. They act on the intracellular receptor for thyroxine, and epinephrine and norepinephrine act on the extracellular receptor. So if you compare them, peptides are usually the large ones. They don't have a protein binding, but there are few peptides which have got protein binding. We discussed about the IGF binding protein and the growth hormone binding protein. They act on the membrane receptor, rapidly metabolized, short half-life with a medium term effect. While steroids are intermediate in size, they bound to the protein, they travel through the intracellular, and they have a slow metabolism, long half-life. So if you want to talk about toxicity, if you're giving growth hormone or if you're giving hydrocortisone, which one will have more toxicity? Or let's say vitamin D in that regards. Because it has got a much longer half-life. And second, it is stored in the blood. Or let's say somebody has taken 100 thyroxine tablets versus 100 sachets of vitamin D. You are going to be much more worried about the vitamin D child than the thyroxine because it is going to go off quickly from the blood from that regards. Amino acid derivatives are very small. They've got no plasma protein binding. Their receptors are usually extracellular, very short acting and rapid effect from that regards. So now we have got the hormone, which is being response, how it happens. So we'll talk about this and then we'll close the session here. We've got two broad group of hormones as I discussed. You have got rapid responses like calcium, glucose and volume. So for that, you need something which is going to act immediately and go out immediately. Then you've got the slow process, which basically are things like bone formation, growth and puberty. So which group of hormones will work here and which group of hormones will work here, Richa? Peptide versus steroids, if you think of it. For rapid control, will you like to start steroids? Peptide hormones are like instant noodles. Within 2 minutes, you will create them, they're going to act and they're going to go. While peptides are going to take a long, it's like Indian four-course meal, it is going to take few hours. So steroids will be good for slow processes, particularly for bone health and for puberty, or you've got long hormones like growth hormone or PTH, which can act for long terms. While rapid regulation, they are all controlled. If you talk about PTH, if you talk about the volume regulation, the AVP, the insulin, they are all the acute short-term hormone pattern which are there. So problems in synthesis can happen because of the pituitary glands. You can have diabetes because of the increased problem in the insulin production, CAH, hypoparathyroidism, hypogonadism. So synthesis defects are very important from a initial clinical perspective. And one of the classical example is the problem in ACTH. Now we have discussed this earlier also in genetics that there are three other things which are produced. One is the MSH, which acts on the MC2 receptor to control appetite and pigmentation, ACTH, which regulates cortisol, and endorphin, which regulates the pain. And when somebody is stressed, you want to eat more, you want to have a cortisol response, you want to have less pain. And this is how one single hormone is regulating everything. And this basically is stored from that perspective. So steroid hormones are typically which hormones are stored and which hormones are synthesized.
Steroids are immediately synthesized.
So steroids are not stored.
Can be stored.
How can they be stored? They are lipophilic, will they not escape?
So
you can either bind them with a sulfation, but usually they are produced immediately. While peptides, big peptides are produced and they are stored. You talk about ACTH, you talk about PTH, you talk about ABP, insulin, they are all stored. So POMC, ACTH will also be there. So now you have a 6-year-old boy with weight gain and hyperphagia, obesity, lethargy and weakness, low cortisol, and low ACTH stimulated cortisol as well. Blood glucose is high. So we talked about earlier somebody who had diabetes with cortisol deficiency. Again, there is a cortisol deficiency. What are you thinking of here with obesity?
basically cortisol deficiency and to know the morphology actually, whether he has any red hair or something
Okay.
present or not.
So he did not have that. So this could be a problem either in the pro-opiomenlocortin or conversion of that compound subsequently can be there. Insulin also is a classical hormone which is produced as a pre-proinsulin, which is converted into a proinsulin, which has got the AB chain and the C peptide, and finally you have got the proconvertase, which is converting it to insulin. So as you said, the proconvertase is defective, so therefore the insulin deficiency is also there in that regards. Now, insulin secretion, of course, is a complicated process, and we all know that this is associated with the ATP status of the child, and it's stored. So 18-year-old girl with increased urine output, sugar is 258, A1C is 8, and ketone is negative. This child is lean, there is no acanthosis. So what type of diabetes are you looking at? Type 1, type 2?
Modi or type 1?
So type 2 is out because we have shown that underweight is not there. You can have an overweight but not underweight. No acanthosis. Type 1 plus minus yes, but it may be an early type 1 diagnosis, but you have to think of other possibilities as well. So labeled as type 1 diabetes, on insulin developed recurrent hypoglycemia at a very low dose. So you're thinking of a monogenic form of diabetes. So this is clearly onset after 6 months without DKA, non-obese. You did a GAD antibody which was negative. So that's why you found that this could be a possibility of a monogenic form of diabetes. So these synthetic defects are important from that regards. Another mechanism which I'll talk about before closing is a double hit model. So many disorders in endocrinology, you have got the first damage which is not going to have clinical manifestation. Then you have a double hit, that there is a second hit which happens and then the problem starts happening. The classical example which I'm going to talk here is that of the star defect. Star, we know, is a steroidogenic acute reactionary protein which responds to ACTH, to the other scenarios as well. From the other regulation, LH, FSH, they regulate the transfer of cholesterol into mitochondria. So if you have a star defect, the problem will be that the rate of cholesterol transfer to the mitochondria is slow, and therefore the rate of steroidogenesis is reduced to 17% of the normal scenario. But 17% is good enough. You will not have a problem. But with time, if the star is not there, your cholesterol is going to be accumulating and it is going to burst the cell. And that is the second hit. So the problem is not with lack of transfer, the problem is accumulation. Similar defects are reported with growth hormone deficiency, where splicing defect will cause storage. Pro-insulin defect, which we talk about, again, splicing defect, insulin will destroy this scenario, and neurophysin defect also will cause this similar picture. So 4-month-old girl with failure to thrive while upon, weight is 3.6, sodium is 120, potassium is 6.5. 17 OHP is normal. So is this adrenal hypoplasia congenita? Okay, so girl child cannot have AHC?
Can have, but unlikely.
So which conditions can have?
Like if the girl has Turner syndrome, then she could have mosaicism high.
If it's
Dimension is high in case.
if it is recessive, both these scenarios there coming from both parents, so it's rare. But what else will you think of? Hyponatremia, hyperkalemia, just the same case. I talked about the boy who had the same scenario. You said AHC, but here gonads are palpable.
This is a case of XYDSD.
Yes.
And presented with salt wasting.
In a female, phenotypic female. So
probably the late onset of this 4 month, we can think about.
So this will classically go in the form of a star defect. So this is something which we can be there. So if you talk about onset of salt wasting, we discussed CAH is first, adrenal hypoplasia congenita is later, star defect is later, and maybe sometimes I have seen pseudohypoaldosteronism at 8 months, 12 months also, because their salt wasting is missed. They don't have pigmentation. They don't have any cortisol deficiency. 5-year-old boy with failure to thrive, Nimisha, weight is 15, height is 96, polyuria from 2 years of age. Urine osmolality is low. Water deprivation shows a lack of response. So this is water deprivation showed a 120, and then AVP response is there. So this is a central diabetes. We discussed about histiocytosis, but what genetic defect can cause this?
Packaging defect of neurophysin.
Yes, so neurophysin gene mutation, this is the second hit model. So it's a later onset manifestation of DI. That is what is important from that regards. 11-month-old girl with failure to thrive, blood sugar is 320, ketone is 1.2, weight is very low, GAD negative.
People look for the genetic testing.
So this is a neonatal diabetes and genetic testing has to be done, and it showed an insulin defect. So what does it mean?
So again, the second double-hit model is there. So the delayed presentation, like in 11 months, with a GAD negativity, autoimmunity is negative.
Yes. So this is again a double hit model. So I talked about 3 double hit: star, we talked about the vasopressin problem and the insulin defect, and they will have a much later onset presentation. And that is not going to make a difference because treatment will remain insulin therapy. So we have discussed